This is part 2 of the 3-part series of medical emergencies. This lecture is going to cover emergencies of the endocrine system, as well as the hematologic system, blood disorders, and we're also going to talk about infectious diseases. So let's start with the endocrine system. Understand that the brain needs to send chemical messages to the organs, the cells of those organs, in order for them to do specific functions, in order to maintain equilibrium, balance, homeostasis. So this endocrine system, it affects every cell, every organ, every body function. It's the way that the brain communicates. And they communicate with a substance known as a hormone. A hormone is secreted and is picked up by a cell. The cell, when stimulated by the hormone, will tell it to do a specific function. It does it by creating a protein. You hear proteins being talked about. What are proteins? Proteins are the language of cells. It's how cells communicate with each other. Proteins are strands of amino acids. If amino acids are words, then a protein is a sentence, is a command. Some proteins are very small strands of amino acids, just like some commands, sentences are small, and some are complex, hundreds of thousands of amino acids. But the way that these amino acid proteins are created are stimulation by these hormones. Hormones are chemical messengers, kind of like emails, that are sent by the brain through the endocrine system and the glands of that system. And you can see the network of glands. We have our master gland up at the top, that's known as our pituitary gland. The pituitary gland controls all the other glands. Other glands in the brain, the pineal gland, it secretes melatonin, which is helpful in allowing you to sleep and have dream states, things like that. In some cultures, it's known as the third eye. We have our thyroid gland, we have our adrenal gland that secretes epinephrine and norepinephrine. Our pancreas, which is part of digestion, secretes insulin, which is necessary to get sugars into cells, and our reproductive glands, which either create sperm or ovum, eggs. And one of the big endocrinological emergencies that we have as EMTs, that we encounter, is diabetes. And we talk about the pancreas for a second. Diabetes is characterized as the body's inability to create insulin, either any insulin, which is a congenital problem called type 1 or juvenile diabetes, or enough insulin to get all of your sugar out of your bloodstream like you will find in type 2 diabetes. Glucose is one of our basic sugars that we need in conjunction with oxygen. The cells use as part of aerobic metabolism to create ATP. ATP is the battery pack of cells. Cellular metabolism requires sugar and oxygen for good aerobic metabolism, and the waste product is CO2. The problem with sugar is it's too big to make it into the cell on its own. It needs a mediator. It needs a hormone to tell the cell to change its cell membrane's permeability to allow this big fat molecule to make it inside the cell so that it can be used for cellular metabolism. This hormone that I'm talking about is insulin. So with diabetes, there's a lack of or an insufficient amount of insulin. So without insulin, there can be no sugar as part of cellular metabolism. Cells begin to starve. they have to burn fat, they have to use other products, and it's not as effective as sugar. The other problem is all that sugar is now stuck outside in the blood, and it does not belong there. Once again, sugar is a big fat molecule, and it becomes a thickening agent for blood that can get in the way of good circulation. So looking at the pancreas secretes insulin that allows this sugar to enter into the cells. Very simple, and without insulin, there's no way you're getting any sugar into your cells. And your blood sugar levels are going to go up, up, up. So like I mentioned before, type 1 diabetes, otherwise known as juvenile onset diabetes, is a congenital autoimmune disease. Now what do I mean by autoimmune disease? I mean that the body does not recognize the cells in the pancreas, known as beta cells. It does not recognize that these beta cells are actually part of the body, so the body attacks them and destroys them. So without these beta cells, these insulin-producing cells, there can be no insulin production. So what happens instead is patients have to rely on an external source for their insulin, and they use they inject themselves with other forms of human insulin or beef or pork insulin. Type 2 diabetics don't have, it's not an autoimmune disease. Their body still produces insulin, but it's not enough to get rid of the sugar that they take in. So sometimes this is known as diet-controlled diabetes, where you have a patient who's usually overweight or elderly, is taking in sugar, but they're not creating enough insulin to get rid of it, so it's stored as fat. So they take these pills that actually stimulate production of insulin. And this is important because you need to be able to differentiate between type 1 and type 2. When you wake up a diabetic and they don't want to go to the hospital, if they're type 1 and they control their own insulin production by injecting it, then that's one thing. But if they're a type 2 diabetic and they maybe took too much of their hypoglycemic drugs that cause that insulin production, an overstimulation, and you just give them simple sugar and then you leave, those drugs are still working and the body is still creating excessive amounts of insulin. It's very common that their blood sugars will suddenly drop again, and you can have another bout of hypoglycemia. So it's a dangerous premise to have a diabetic refuse transport to the hospital. If they do, you have to make a differentiation. Do they inject their own insulin, or are they taking medication to stimulate insulin production? And share your findings with a physician to make sure that the patient has an informed consent not to go to the hospital. Regardless, both types of diabetes are potentially lethal, but they're easy to regulate. Type 2 is more common than type 1. Make note of that. So how we treat our diabetics, it really varies by each individual patient. Their need for glucose might be different than another person's need for glucose. The bottom line is the ultimate goal is to get them evaluated at the hospital to find out why their blood glucose level dropped, because they are supposed to be able to support blood glucose levels in a normal way, and having it drop too precipitously could be a sign of other underlying problems, like an infectious disease, like stress, or even trauma. So remember, like I said, glucose, the major source of energy for the body. It works in conjunction with oxygen to create a metabolic process known as aerobic metabolism. Cells need to charge their battery because they can't plug in anywhere. They work off of battery power. This battery is known as adenosine triphosphate, or ATP. Burning sugar and oxygen through the process of aerobic metabolism creates 32 molecules of ATP. and the waste product is CO2. This is normal. This is way the body should operate all the time. Not having oxygen, you can still burn sugar, but that's anaerobic metabolism, and you only create 3 to 4 molecules of ATP, and the byproduct is lactic acid. You find this a lot with hypoperfusion, shock patients. But you can still create energy without sugar. You burn fat with oxygen. You create about 28 molecules of ATP. Sounds good, close enough to aerobic metabolism. But the waste product for that is a substance known as ketones. And ketones are acidic, and they create a sort of metabolic acidity known as ketoacidosis. And for diabetics who can't get sugar into the cells and are instead burning fat, this is known as DKA, or diabetic ketoacidosis. It's a form of metabolic acidosis that while it's a gradual onset, is a severe medical emergency that can cause death. So without insulin, we end up with a buildup of sugar in the bloodstream, and that in itself is dangerous. So classic signs of uncontrolled diabetes and the precursor to DKA: polyuria, frequent painful urination; polydipsia, frequent drinking; and polyphagia, excessive eating. Now let's describe why the body is doing these. Okay? Polyuria, excessive urination. Remember, the system that regulates the metabolic acid-base balance of the body is the renal system, the kidneys. So with all of these ketones being produced, because you're burning fat, you don't have any sugar making it into the cells because there's no insulin production, all these ketones have to get excreted out, and the kidneys start working harder. They got to make more urine with these ketones in them. And because they're making more urine, there's a stress on the body. It gets a little dehydrated. So we have a lot of drinking. They're very thirsty. In addition, the body is under the impression that it's starving because it wants sugar. Ultimately, it wants to undergo aerobic metabolism. This whole burning fat thing with ketone response and waste product is a secondary system. It's a part of the starvation process. So they're going to want to eat more, and that's where you get the polyphagia. So hyperglycemia, which is uncontrolled diabetes, and hypoglycemia, which is low blood sugar, are true diabetic emergencies. They have neurologic issues because the brain cells are so sensitive to levels of blood sugar. If you can't get sugar into any other cells, you certainly can't get them into brain cells. So the brain cells are burning fat. They don't like that. They get very irritable. So you feel like you get aggressive, you get slurred speech. It looks like you're intoxicated. And if your blood sugar drops enough, or your blood sugar goes high enough, you can become completely unresponsive. So remember, with hyperglycemia, food intake is going to be excessive, whereas with hypoglycemia, it's not sufficient enough. Insulin dosage, inversely, is insufficient in hypoglycemia, but it's excessive in hypoglycemia. Okay, so with the signs of the body feeling like it's starving, in hyperglycemia, there's going to be a gastrointestinal change. There's going to be increased thirst, increased hunger, because you want to get sugar. The body doesn't understand it. The sugar's there, they just can't carry it across because there's no insulin. So remember, diabetic ketoacidosis is caused by burning of fat. The waste product of fat is ketones. And if we have built up enough ketones, it becomes ketoacidotic, because ketones are acidic in nature. Now, if your blood sugar goes so high, you're in the 600s, 700s, this is known as HHS, or hyperosmolar hyperglycemic state. Your blood is so thick from the sugar buildup that's actually drawing fluid from your cells. it can clog your capillary beds. The capillary beds are designed to be one red blood cell thin, and you got some sugar molecules that can fit in there, but if it's all sugar, it's going to dam up and gum up those intricate vessels, and that can lead to things like neurologic insufficiency, blindness, loss of limbs, like toes and fingers. So diabetic ketoacidosis is when glucose is not available, the body wants to go into a starvation mode. It burns the fat. It's able to do that. Now, when the fat's broken down, those ketones and fatty acids, they're the waste products. So now, as you're becoming metabolically acidotic, with all these ketones and fatty acids building up, your kidneys are trying to urinate it out to balance, but also your respiratory system, which controls acid-base balance in the blood, it wants to kick in as well. So it's going to start getting rid of CO2, another basis of acidosis. So what's going to happen is you're going to get deep, clear respirations known as Kussmaul's respirations. It's an attempt by the respiratory system to combat the metabolic acidosis being caused by the buildup of ketones and fatty acids from burning fat, from metabolism. So with HHS, remember that the body can be producing some insulin, but you end up with such high sugar levels it can't fix the problems. And basically it's trying to get rid of this excess sugar in urine, and that can lead to supreme dehydration. It will also shunt all the fluid from the tissue into the vasculature to try and balance out the plasma because it's so thick with the sugar. So when you're hypoglycemic, it's otherwise known as insulin shock. These are patients who you find who are usually having issues with their insulin and they did not eat. So they've taken too much insulin, or the pills they took too soon before they ate. They didn't eat enough food. They've engaged in vigorous activity. Diabetics have to restrict their activity levels. And sometimes brought on by sickness, they vomited. And these are issues that we have to correct. This is a serious thing because it can lead to seizures, coma, and death. Other complications, because of the thickness of the blood, you think about vaso compensation and being able to perfuse. So damage to nerves, blindness, kidney damage. These are known as neuropathies. And the nerves need to have blood supply too, and it's a fine network, and if they get clogged up, the nerve endings begin to die off. Circulatory disorders, we end up with heart attacks, strokes. Thickness of the blood can lead to vascular disease, chronic hypertension, high levels of cholesterol because they're burning the fat, the amino acids. Skin sores as they lose blood supply to the skin begins to break down. In children, type 1 diabetes, usually about the age of 5 they present with it. That's when the immune system begins to fully get involved and it begins to attack the beta cells. Children who are diabetics are prone to severe dehydration and elements of hyperglycemia, and in hypoglycemia they can seize. In the elderly, they develop type 2 diabetes, but they've had a normal endocrine system, normal insulin production. Just with age, the insulin starts to, fewer and fewer insulin is being produced, and as a result, we're having a buildup of glucose since their diet habits don't change. And because of the neuropathies, these are the patients that have the silent MIs. They don't have the chest pain. So our assessment of diabetic emergencies, well, of course, any patient who's unconscious, we want to be hyper aware, size up the scene. Okay, we want to ensure scene safety. Because sometimes you might have a free needle laying out there. They might have just taken their insulin and passed out. Be alert for clues that it's a diabetic emergency. Think about the mechanism of injury and the nature of the illness. You may be called to a police precinct to clear a drunk, as they call it, somebody who's been pulled over for DWI, who's refused a breathalyzer, they have them in the holding tank. It's up to you to size up the scene and look for other clinical clues that it might not be intoxication, that this patient might actually be a hypoglycemic diabetic. Form that general impression and look for any life threats that you might find. Determine their level of consciousness, right? Be aware of the ABCs. Oxygen really should be playing a major role in treatment of our diabetics, either hypo or hyperglycemic. Fruity odor on the breath, you know, that's something you can look for, but if you've got Kussmaul's respirations, they're a known diabetic, and they're unresponsive, I would jump to the conclusion that's DKA with or without the fruity breath odor. Manage this respiratory distress with oxygen. The Kussmaul's respirations are compensatory to try and get rid of the excess acid that's in the blood. It's not effective because the only way to get rid of that type of acid is out of the kidneys, but giving oxygen can definitely assist. Circulation, when you're hyperglycemic, it's warm, dry skin, whereas with hypoglycemic, it's moist, pale. You can have a rapid, weak pulse in both. And make our transportation decision on what we're going to do. Paramedics carry IV glucose. If you have an unconscious patient, you don't want to give them anything by mouth. But usually these patients, they're not the ones who called, someone else called for them. So get a good history from family and your surroundings as well. Look for signs of hypoglycemia. Tremors, abdominal cramps, vomiting. With hyperglycemia, they can have the fruity odor, but once again, it's not a real red flag. It's not in every single case. So don't change your diagnosis because you don't detect fruity odor on the breath. Instead, focus on mental status. Are they able to assist in their own care? Can they swallow some sugar? Can they protect their airway? Pulse oximetry is big to check for perfusion. And during transport, keep reassessing your patient. And the best way to do it is to talk to them if they're conscious. If they're not, keep focusing on the ABCs. Make sure their airway stays open and intact, you know, and patent. Make sure that they're getting oxygen, checking their pulse oximetry, make sure there's between 95 and 100%, and document any changes that you find. If you don't have the ability to check blood glucose levels and you're not sure if this patient is hyper or hypoglycemic, there is no harm in giving them more sugar. You're not going to affect their hyperglycemic state any further by giving them sugar by mouth if they're conscious and they're able to swallow. But you're able to quickly address their hypoglycemia by giving them that Instaglucose or whatever glucose gels you carry on the ambulance. So don't be afraid to give it when you have somebody you suspect is a diabetic and they have a change in mental status. And they're conscious and they're able to swallow. If they're unconscious, like our friend in the slide down there, where I think we're doing other things like chest compressions, that's a little more advanced, and we don't have to worry about giving oral glucose, but you definitely would not give oral glucose to an unconscious patient. That patient, the only way they can get glucose is through IV bolus, and that can only be done pre-hospitally by ALS. And that's important. In addition to the IV glucose, paramedics can administer a drug intramuscularly called glucagon. Glucagon is a hormone also secreted by the pancreas, but secreted by alpha cells in the pancreas. And what glucagon does, it's a hormone that locks onto receptors on the cell membrane of liver cells. And what liver cells do is that they store glucose for ready use, not as fat, that's long-term use, but as glycogen, that's for quick use. So when glucagon is caught, that hormone is caught by a receptor, it activates a protein that tells the cell to convert their glycogen stores into glucose and release it into the bloodstream. So you can get blood glucose raised by giving glucagon. It's a little slower than giving the 50% dextrose IV bolus. That's a fast bolus of sugar going into the bloodstream, but it is telling the liver cells to release their glycogen stores, and we'll see a slow increase in blood glucose, and therefore the patient will start waking up. You may see that it takes about 10 to sometimes 20 minutes to bring someone up, their blood glucose up, by this method of glucagon administration. Okay, now let's talk about some blood disorders, hematologic emergencies. Having a good understanding of anatomy and physiology is key. This is what medicine is all about, the fundamental knowledge of anatomy and physiology to make your medical decisions. So hematologic emergencies, it's something that you need to know about. It's not things that you can readily treat, but these patients need your care in getting to the hospital. Hematology is a study of blood-related diseases. Some major blood-related diseases that we experience in EMS are sickle cell crisis and hemophilia. Okay? Understand that the way that the body can function and the way that cells can go through their process of aerobic metabolism is to have good blood supply. Now there are disorders with this fluid of life. We have problems. Usually these are chronic issues. So remember the components of blood. The blood is made up of formed elements and plasma. Now the formed elements that I'm mentioning are red and white blood cells along with platelets. So red blood cells with their hemoglobin protein transport oxygen. White blood cells are part of the immune system and effectively destroy foreign pathogens and diseases. Platelets form clots, which are the spackle that keep the vasculature working. And plasma is the fluid that transports all of these cells together. By definition, blood is deemed to be loose connective tissue. Let's talk about a couple of genetic congenital diseases. Sickle cell, an inherited disorder where red blood cells are actually almost crescent-shaped. And this is a genetic trait that's predominant in African Americans and Mediterranean descent races. It looks like a crescent-shaped moon. And the problem with these oblong-shaped red blood cells is that they get stuck in joints in small areas, and they're very poor oxygen carriers. They have a protein called hemoglobin S that does not seat 4 oxygen molecules. Might seat 1, at the very best 2 oxygen molecules. That's not good enough for cellular metabolism, and they'll show signs and symptoms of anemia. Red blood cells that are sickle cells don't live that long either, about 16 days, so there's a constant reproduction of these red blood cells. And you can see what happens with sickle cell at a bifurcation or joint area of the cardiovascular system. It will get stuck and cause a damming up of the area. Now, this can cause a rupture, and in the microvasculature, the arterioles and the capillary beds, that can be easily resolved. You might see some bruising, and the capillaries will restore somewhere else. But major problems are when these get stuck in the spleen. A lot of splenic dysfunctions and destruction occur when you have too many sickle cells that lodge in the spleen. So patients who have a history of sickle cell anemia, who have left upper quad pain where the spleen is located, that's a serious emergency. So there's different types of sickle cells. You have the vaso-occlusive crisis, where the blood flow is restricted. You have the aplastic, so they're not producing enough hemoglobin. The hemoglobin is poor and not transporting oxygen like it should, and we end up with anemia and some hypoxemia. A hemolytic crisis, this is when you have a drop in our hemoglobin levels, another type of anemia that can lead to hypoxia. And then an enlargement of the spleen, a splenic sequestration crisis, that can lead to splenic injury, damage, or even destruction. Other complications that can occur with sickle cell, they can have strokes, gallstones, ulcering, chronic pain, pulmonary hypertension, pulmonary embolus, chronic renal failure. So sickle cell crisis is, it has, since it encompasses the blood, can deal with almost any organ and any organ system and disrupt their normal function. Now, clotting disorders that we have, those are red blood cell disorder we have with sickle cell. Clotting disorder, the inability for the blood to clot appropriately. Thrombosis is the development of clot. A thrombus is, by definition, a clot. So clots are good when they're serving a purpose, like spackling a hole in the vasculature. But thrombus that develops on its own, where it shouldn't be or where it's not needed, can restrict blood flow. Thrombophilia are patients who, thrombophiliacs, develop clots constantly. And the number one cause of death for thrombophiliacs is pulmonary embolus. So these patients need to take blood thinners. And it's either aspirin or Coumadin that you find these patients on. Right? So that's a problem, especially in trauma, because they're taking medication that's prohibiting them to create clots. And now when they need to make a clot, the body can't do it because of the medication. So that's a problem. Other risk factors for thrombophilemia that can bring it on. Anybody who's had recent surgery, this is a non-congenital type of thrombophilemia. Recent surgery, somebody who has been laying in bed for months, they've recently had, like, let's say, a fractured leg and they can't get out of bed. Patients with congestive heart failure, different cancers, respiratory failure, people who are over 40 years of age, smoking, oral contraception can all bring on a clotting disorder. Inversely, hemophilia is the inability to form clots. This can result in uncontrolled bleeding. Our bodies are constantly rupturing the very fine vessels, the micro vessels that we have, the capillary beds. You know, they're always breaking under stress or just a sudden change in blood pressure or external trauma, and then they repair themselves without you even knowing it. People who have hemophilia, they don't have the ability to repair on the go. There's two different major types. We have the most common type, which is hemophilia A. And these are low factor 8 hemophilias. A clotting cascade deals in different factors. There are up to 12 different factors that can cause a clotting cascade, of the aggregation of platelets to the area where there's a rupture, to the creation of fibrin, to the adherence of the platelets and the red blood cells on the fibrin web to create the clot. All these different factors have to take place, and if we miss one factor, the whole chain can fall apart. And this is what happens to hemophilia. So our assessment for patients with hematologic issues, first of all, we size up the scene, make sure it's safe for us to enter. Okay? And in addition, wear gloves and eye protection for our sickle cell patients, because they have some issues with immunoresponse because their spleens are affected and can be damaged. The spleen plays a major role in infection control. Think about ALS support. These patients do well with fluids and with pain management. Do a thorough ABC primary assessment. Okay? Don't get distracted by pain. Make sure that their airway's clear, they're breathing okay, and they're not showing signs of shock. For patients with breathing troubles, open the airway. If they're unconscious, try an OPA. If that doesn't work and there's no sign of head or facial trauma, try for an MPA. You want to get the tongue away from the back of the throat. Give oxygen. You may need to assist ventilations and monitor. Circulation with sickle cell patients, in a crisis, they'll have an increased pulse rate. With hemophiliacs, look for signs of acute blood loss. Look for incredible bruising around anywhere. It could be the arms, legs, chest, abdomen, head. Look for signs of hematomas, things like that, that show that there's a rupture. They're going to have a hard time clotting. Take a history, find out what medications they're on, what type of hemophilia they have, what hospital they go to. Look for other signs of sickle cell crisis, swelling of the fingers and toes. Some male patients have the priapism, and sometimes they have jaundice if their liver is damaged. So you want to ask, do you feel the pain in one location, like the left upper quadrant, which could be the spleen, or is it all over, is it in your joints? Any visual disturbances could have problems with blockage of the optic capillaries. Get a sample history. If you had this before, what happened? What pain medication you take? Did you take the pain medication before we got here? You know, do you respond well to oxygen? These are all things you want to ask. Doing your secondary assessment, you know, focus on major joints. See if it hurts with movement. And really, oxygen helps because it dilates arteries. And by dilating the arteries and the arterioles, you can restore blood flow. And reassess vital signs frequently. Is there going to change their mental status? Are their ABCs okay? Reassess your interventions. Is the patient responding to your current interventions? Do you need to adjust? So what we're looking at here is mainly supportive and really treating acute problems with the airway, the breathing, or circulatory collapse or compromise. You're focusing on that. There's no cure for sickle cell. There's no cure for hemophilia. You know, just recognizing that it's there is enough, because the way you're transport your patient, be cautious with hemophiliacs that you don't bruise them by just moving them on stretcher. Okay, these are things you want to take into consideration with your overall care. And finally, we're going to talk about infectious diseases. So once again, having that knowledge of anatomy and physiology is going to help you. This is the whole basis of medicine, taking that fundamental knowledge and making it work for you in the emergency setting. Now, communicable diseases. It's an infectious disease that can be passed from one person to another. And there are different pathogens that can cause these infectious diseases. You know, like common ones we have are bacteria, viruses, but we also have fungi, protozoa, living organisms. You know, these organisms that there's stories of protozoa that are in pools, like amoebas that are brain-eating amoebas. I mean, there's some nasty things out there. So we have to be very, very careful when we treat our patients that we don't get infected with what they have, because what communicable from one patient to another patient is communicable from patient to a provider. Now, there's different ways you can transmit communicable diseases. There's direct contact through either bloodborne pathogens or sexually transmitted diseases. Indirect contact is transmission of a pathogen that was on an inanimate object that was left by the patient. So a perfect example of that would be your stretcher. So you have a patient who is infectious, put them on the stretcher, transfer them over in the ER, you didn't clean your stretcher appropriately, that pathogen is now on the stretcher, you bring it into the next patient's house, put them on it, guess what? They've just got an indirect contact with the last patient you had, and now they're sick with the same disease that your prior patient had. So practicing infection control is vital in our field. Another route of transmission is airborne. Very, very common, especially for viruses, to be transmitted. Flu season, you know, sneezing, always cover your mouth when you cough or you sneeze, because it's in the droplets. Contamination can also be transmitted through food, contaminated food, or water. The organism can live in there, uncooked meat, water that has been untreated can have organisms in it that you ingest into your GI tract that can then start to cultivate down there. Now, a transmission known as vector-borne is when you get an infection from an animal. It's a cross-breed infection. We see this with viruses. You get a pig virus or an avian virus, a bird flu, that actually can transmit from an animal to a human. Our goal in EMS is to make sure that we don't get sick. That's our primary goal. As far as scene safety, the most important person at the scene of any emergency is you. So OSHA dictates risk reduction and prevention, and they publish guidelines about ways to reduce risk of not only injury but infection in the workplace. So anybody who has to handle bloodborne pathogens is given training. Anybody who is handling patients who have possible infectious diseases is trained. Like EMTs, we have that training and we understand barrier devices when we're dealing with these patients. This is known as standard precautions. Standard precaution is now the new thing. It has replaced body substance isolation and universal precautions. It's the standard precautions, and that's an important thing to understand. Okay, make the assumption that everybody's infectious. Everybody you come in contact with is infectious. Everybody you come in contact with that you're doing patient care on, you're going to have intimate exposure with, meaning you're going to be touching them. That is a potential route of communication, so you need to protect yourself. And we can include, but not limited to, hand washing. Always wash your hands after every patient contact, when you can. If you can't wash your hands, then use an alcohol-based gel. That's good, but hand washing is best. The Ryan White Law, passed in 2009, Part G, mandates that every emergency agency has a designated infection control officer. And this infection control officer, they're the ones who are contacted first by the hospital when their agency has transported or been in contact with an infected patient of a communicable disease. Then it's up to the infection control officer to get in touch with the provider. And everything goes through the infection control officer. So the provider does not contact the hospital directly and get results directly. It all goes through the infection control officer, and this is the way we maintain confidentiality. But understand that infection control starts with you. Maintain your ambulance. Just like the old saying goes, you want to leave the ambulance the way you found it. You know, this is, you want to have every patient contact should be a brand new ambulance. When you move your patient over to the emergency department, what you are basically doing is discharging them from your ambulance. So you have to have a discharge plan. And part of your discharge plan is to prevent indirect contact and communication of disease. And the way you do that is to clean your ambulance, your stretcher, your equipment after each patient contact. In addition to dirt and dust, remove blood. Any blood you see, no patients should share one sheet. New sheets, and clean your stretcher. And I'm not talking about clean and just wipe it dry. We have to have something called wet time. Proper disinfection with 10% bleach solution with a 2-minute wet time, meaning you clean it, you leave it wet, and then you let it air dry. And it should take at least 2 minutes. By doing that, the bleach will destroy any organism, virus, pathogen that you can come across. Bleach does it. It's a heavy-duty alkali or base. It does it through liquefaction necrosis. It destroys the cell membrane. So after 2 minutes of this exposure, it's a bleach environment, even at 10%, nothing can survive. So you've basically disinfected your stretcher, and do the same thing for any area that's come in contact with that patient. Think about it. When was the last time you cleaned your blood pressure cuff? You're going to be using pulse oximeters. You're sticking patients' fingers in there. When was the last time you cleaned the inside probe? All different things you have to think about as part of good infection control. We also have high-level disinfection. Now we're talking about hospital-based stuff. High-level disinfectants for surgical equipment and stuff, and then we have sterilization, which kills all microbials. We're talking about burn centers, things like that, we don't want to have any infectious agents in the unit at all. So remember, on every call, strip used linens, discard all disposable equipment, clean contaminators with 10% bleach if you have it. If you don't have it, soap and water, and let it air dry for at least 2 minutes. Create a schedule for routine cleaning. Your cleaning should be at the beginning of your shift. You should start your shift with a clean ambulance. Take the extra time. And if you're a supervisor, have a written policy in place. Because you need to reduce the risk of not only you getting an infection, but becoming an actual disease-spreading vehicle and infecting everybody in the community because you don't properly disinfect your ambulance. And one very common disease we have out there is methicillin-resistant Staph aureus, or MRSA. This is a disease that primarily attacks the skin. It's resistant to most antibiotics and very common in people with weak immune systems. Other types of diseases we have, tuberculosis, which is an airborne respiratory disease. People with an acute onset of TB, active TB, present with fever, coughing, night sweats, weight loss, productive sputum, sometimes bloody sputum, chest pain. You're at risk of exposure if you're in close contact. Being in the back of an ambulance is considered close contact, so be aware. And the best way to treat these patients is with a barrier device on their respiratory, on their airway. The best thing we have right for that is a good negative pressure mask, which is a non-rebreather. If they're short of breath and they're coughing up blood, you should give them a non-rebreather. They need oxygen. At the same time, you're creating negative pressure, so if they cough, those droplets will not be able to make it over to you. Other types of viruses that exist in the body and never go away are herpes viruses. And there's all different types of herpes viruses. The herpes viruses that we talk about are as simple as chickenpox to our simplex viruses. Oral herpes, type 2 is genital herpes, but these are skin infections. HIV, we're all aware of. This disease actually attacks your immune system and destroys your white blood cells. If your white blood cells drop below a certain level, these T cells drop below, let's say 500, you have AIDS. And what happens is you don't die of HIV, you die of the common cold because your body cannot defend itself. And that's what makes AIDS fatal. HIV is not easily transmitted. It's only really done through direct contact, bloodborne or sexual contact. It only lives outside the body for about 12 seconds on average. Other types of diseases we find, syphilis. This is a sexually transmitted disease, a bloodborne disease. It has neurologic consequences, complications. Usually, once given penicillin, the individual is considered non-communicable. and easily managed. Before antibiotics, and if left untreated, this can have progressive stages to it that can lead to neurologic deficits, seizures, and death. Hepatitis is an inflammation of the liver, and there's different types of hepatitis. In addition to this, you have loss of appetite, fatigue, jaundice, right upper quad pain, and you can't tell who's got hepatitis A, B, or C just from appearance. So you have to treat everyone as if they're highly infectious. But just note that these are diseases that are blood-borne in nature. But hepatitis can stay active in dry blood for up to 7 days in some cases. So, unlike HIV, you have blood on your ambulance, it's possible that it's infected with hepatitis, even though it's dried and has been there for a couple of days. Meningitis, swelling of the meninges, signs and symptoms, well, it's meningeal, so it's going to be neurologic. Fever, headache, stiff neck, change in mental status. There's viral and bacterial. Most meningitis is not contagious, but treat all cases of meningitis as if they are. And this is, in New York State, is a reportable disease. Pertussis, known as whooping cough, airborne disease, and happens a lot in children. And it is a highly contagious disease. Usually prevented with vaccination. If you're vaccinated against pertussis, you won't get it, even with exposure to a patient with it. Bronchiolitis is a viral disease that inflames the bronchioles, usually in children and infants, and it's a precursor to asthma. Before you're diagnosed as having asthma, you have to show a year of signs of bronchiolitis, inflammation of the bronchioles, before you have that reactive airway disease. And the reason why is because bronchiolitis can be viral in nature, and you can never have it again. A type of disease called bronchiolitis obliterans, the bronchioles get so inflamed they get plugged with granulation tissue, and that can lead to respiratory arrest. Now this respiratory syncytial virus, this is an inflammation of the lungs, secondary to infection. It can cause pneumonia, it can cause croup, depending on where it is in the lungs. If it's all the way lower, it'd be bronchiolitis and pneumonia. If it's upper by trachea, then it's croup. It's highly contagious, spread by air droplets. So patients who have, like, you're dealing with a child with croup, with a croupy cough, just know that they're infectious. So oxygen is a big thing, and making sure that you have that barrier in place. Humidified oxygen is great, and it's negative pressure coming at the patient, so when they cough, the droplets won't transmit. The leading cause of pediatric death worldwide is pneumonia. It's an inflammation of the lungs, and it's often secondary to another infection that, through your coughing and production of sputum, has created this opportunistic pool of this location in your alveoli that becomes infected. People who are predisposed to pneumonia, people who are on vents, who've been on, have the same endotracheal tube in place for an extended period of time, they're prone to it. COPD, cancer patients, immunosuppressed, HIV patients. These are all people who are susceptible to pneumonia. Bacterial pneumonia comes quickly, high fevers, and then the body knocks it off, especially antibiotics, goes away. Viral pneumonia, more gradual, less severe, but the symptoms vary, and bacterial is the more dangerous of the two. If left untreated, it can cause death. Croup, like I said before, is a type of virus. It actually causes inflammation of the larynx. Hallmark signs are that seal bark cough, the virus that causes croup is contagious, but croup by definition is not contagious. But coughing that droplet up and can be transmitted that way. Epiglottitis is a bacterial infection that causes an inflammation of the epiglottis. That's the covering of the trachea. Every time you swallow, the epiglottis closes over the trachea so you don't swallow food into your windpipe. When this epiglottis becomes inflamed, it can cause some airway compromise. And because this epiglottis is inflamed, the body thinks that it's trying to swallow something, so it begins to hypersalivate and you get that drooling appearance. Now, a very common disease that's spread from species to species is West Nile. Mosquito can infect humans and birds with the West Nile virus. But it's not something that's communicable from human to human. It's a very interesting type of disease. SARS, on the other hand, is highly contagious. It's a potentially life-threatening viral infection. It starts with flu-like symptoms that can progress to pneumonia and then lead to respiratory failure and death. And it's transmitted close person to person, and it's a major problem in EMS. If you have somebody who is in respiratory failure, secondary to SARS, paramedics will try and intubate them, or they'll be wheezing and you'll give them nebulized treatment. Just realize that those droplets that's coming out of the nebulizer, or if you get your face all the way down next to their airway and they cough, you can get infected. Viruses that originate in the bird population are known as avian flus. Infected birds can cross-contaminate to humans with this type of virus. But the issue with this is no human-to-human cases have been reported, so it usually dies off with the patient who was infected by the bird. Now, swine flu is a little bit different. This is something that can be picked up by an animal and then is contagious. We have different types of H1N1s now. Since viruses are able to change their shape and structure, we have now H3N7s. This is all different types of viruses that originate in pigs that are transmitted to humans. It's one of many different types of influenza viruses that are out there. So, what should we do with patients who present with infectious disease? Our standard precautions should be enough to prevent, but we treat them like any other medical patient. Our primary assessment, remember again, we focus on our general impression, mental status, airway, breathing, circulation, priority determination, and transport. Use the OPQRST to find out when they developed, what other signs and symptoms they have. Get a sample history. Don't get focused on just the fever and think that's it. There could be other underlying issues going on. And recent travel to areas at risk, like the Far East. This is where viruses first come out. It's China. Now we're seeing it in the Middle East as well. So finding out travel schedules of these patients is very important for follow-up at the hospital by the Centers for Disease Control and other agencies. We got to focus on respiratory involvement and really use your oxygen mask as a negative pressure mask. Instead of putting on just a regular mask, give them oxygen. That negative pressure is going to help them and you. If you suspect somebody has epiglottitis, they're drooling and coughing, we don't want to manipulate their airway excessively. We don't want to stick an oral airway in. We can end up causing more inflammation in the epiglottis and complete airway obstruction. There are times, especially during critical transports, where you have aerosol generating procedures going on. The real school of thought is to wear HEPA filtration masks when you are using this for somebody who has a communicable disease. In New York City, there's actually a SARS protocol that, when activated, limits the use of aerosol medications and intubations. Most important thing to remember in treating these patients, as well as any other patient, is of course your safety is paramount. Standard precautions are key in all of these medical emergencies. Thank you.